We are live.
Good evening. Welcome to something new that Indian Journal of Ophthalmology has started. IJO prides itself in publishing evidence-based articles and review articles time to time. But when there is an emergency situation, you can't wait for publications because publications do need time, even if it is expedited. So we have started this initiative where we will gather a group of experts and try to arrive at a consensus on topics which are of an emergent nature, such as TASS, which is currently sweeping across India. So hence this initiative of having this webinar. We have an expert group which is going to speak on various topics, several case presentations, and an expert panel as well. I request our moderators, Dr. Somashila Murthy from LV Prasad Eye Institute and Dr. Partho Pratim Datta Majumdar from Shankar Nethralaya to take it on from here.
Good evening, everyone. Once again, I would like to congratulate IJO for bringing up this very timely webinar and discussion that we're going to have over the next couple of hours or 2.5 hours. The format of this evening is to have 4 presentations by experts in this field, followed by 5 case presentations, which we hope to discuss threadbare, and hopefully a lot of audience questions during this time for everybody to really clear their minds about what TASS is all about. And then followed by which we will have faculty interactions with our panelists, who are all of them esteemed, renowned surgeons across India, and followed by, or including comments from the domain experts who will be part of this entire endeavor for this evening. So with that, I hand over to my partner for tonight, Dr. Partha, to introduce the first speaker for this session.
Good evening, everyone. So let us first welcome all the panelists who are available with us today. So we have Dr. Padma Shri Dr. Mahipal Sajdev, Chairman of the Center for Sight, a chain of eye hospitals in India, and one of the pioneers of phacoemulsification procedure in India. Dr. Lalit Verma, the President of All India Ophthalmological Society and Secretary General of South Indian Academy of Ophthalmology, a renowned vitreoretinal surgeon. You'll be joining soon. So we have with us Dr. Samar Basak, the Vice President of AIOS and Head of the Department of Cornea, Disha Eye Hospital. We have Dr. Namrata Sharma, Honorary General Secretary, AIOS. We also have Dr. Rajesh Sinha, Honorary Secretary AIOS, Professor of Ophthalmology, Cornea, Cataract and Refractive Surgery Services at RP Center, AIMS, New Delhi. We also have Padma Shri Dr. T.P. Lahane sir with us, who had served as a Dean of the Grant Medical College and JJ Hospital, Mumbai. He is the man with the world record of performing cataract surgeries. We also will be joining with us soon Dr. Jeevan S. Titial, Chief of the RP Center, AIMS, New Delhi. And we also have Professor Ritu Arora, a reputed eye surgeon and Director of Guru Nanak Eye Center, Delhi. We also have Dr. Rajiv Raman, Senior Consultant, Vitreoretinal Services, Shankar Nethralaya, Chennai, and Adjunct Faculty of Department of Engineering Design, Indian Institute of Technology, Chennai. We also have Professor Rohit Saxena, and we will be joining soon Dr. Lalita Prajna, ocular microbiologist from Arvind Eye Hospital, and Dr. Sabyasachi Sengupta, who is a vitreoretinal surgeon and the current associate editor of the Indian Journal of Ophthalmology. He has published a large series on incidence and long-term outcome of TASS in almost 60 eyes when he was in Arvind Eye Hospital. So let's now come to the most exciting session of this evening. So let me invite our first speaker, Dr. Haripriya Arvind, who is the Chief of Intraocular Lens, Cataract Services at Arvind Eye Hospital, and currently heads the Cataract Clinic at Arvind Eye Hospital, Chennai.
I think you'll have to just wait for a minute, because I think she called me up to say that she's having problems in logging in. So she's not logged in presently.
Okay. Meanwhile,
Okay.
chairpersons can make the opening remarks, Dr. Mahipal and Dr. Lalit. Please.
Lalit, Dr. Lalit.
Sure.
Yeah,
No, I think our country is facing a tsunami of this TASS reactions, and I was surprised to see so many, not only from one state but all across. And I thank Mahipal and Dr. Chetan for making the membership aware of this reaction, and Mahipal made me join this group, and then I realized the enormity of the problem. And then we immediately, IJO swung into action, and we had a meeting yesterday, in fact, in the morning on the Christmas day. A lot of people across the country had joined. The basic purpose of that meeting was, the way AIO should move forward. AIOS did issue an advisory to all its members regarding caution in the use of this particular batches of IOLs. And based on the feedback which we received yesterday, AIS again swung into action again today, and we have started working on a couple of points which were advised by all the respected members yesterday. And in fact, 2 emails have been dispatched today only to all its members. And I am aware of all the seriousness of the issue. And as I said yesterday also, AIS is not going to be mute to all these issues. And we will, as was advised by a lot of people yesterday, have started procuring samples of the IOLs from the members. And today also 4 people sent samples. And these samples will be tested for endotoxins and monomers at a government-approved labs, so that we can have unbiased, unbiased review of not only the IOL but the solutions, the visco. In fact, anything which goes inside the eye has a potential to cause this inflammatory reaction. So we will have an unbiased view, and we have also prepared a Google survey form, and I will request you to fill up that form, because we have also written a letter to DCGI, to care group, to all the members, so that we will, by the end of all this, have a data that what is going wrong where. As of today, what we understand today is that it is the hydrophilic lenses made by one particular company which is responsible for majority of the inflammatory reaction. So I thank the initiative taken by Santosh, Mahipal, and the entire group. Sabyasachi Sen and so many learned people are here, Partho Majumdar, who will dwell upon the various causes of this inflammatory reaction. Because let's understand, all of us, that our basic focus is that no patient should have a serious reaction for no fault of ours, because the doctor uses all these products, marketed by A, B, C companies in full trust, and we use it because at that time we do not, and AIOS website will also have a continuous, on its website itself, a form where members can fill up the ADRs, so that around the year we will be involved in activities of determining these endotoxin monomers, not only of one company but of other companies also. This was what was advice given to me yesterday by a lot of members. So with these few remarks, I hand over back to Dr. Mahipal or Santosh to take this forward, and look forward to more suggestions being received from this particular webinar also.
Thank you. Dr. Haripriya, are you ready?
Yes, I am, sir.
Okay, fine. I think we can start with her. Thank you, Lalit. I think great for AIOS to take up this issue, because it is causing a lot of difficulties to a lot of doctors, and often doctors have kept quiet and have always incriminated themselves or their autoclaving procedures or their surgical procedures as to something wrong within them. And I think this is the first time that AIOS has come out, and the people are taking this in the proper direction. And as you have rightly said, there should be a continuous, ongoing kind of a situation, ongoing area or a place where we should be able to express our concerns as regards any products that are coming in. And I think this session will give the highlights as to what exactly TASS is, how to differentiate it, what to do, etc. While AIOS is taking the action vis-a-vis the drug controller and all those things. and trying to find out the cause. I think this is more to educate the ophthalmologist as to what exactly is TASS, how to handle it, how to do a differential diagnosis, etc. So I think without much ado, we can start with the first presenter, Dr. Haripriya, please.
Thank you, sir. So now we have already joined with us Dr. Amulyanath Sahu, a surgeon par excellence and founder chairman of the International Society of Manual Small Incision Cataract Surgery, and Dr. Chitra Ramamurthy, the dynamic chairman of Academic and Research Committee of AIOS. So let's move on to the first speaker. So our first speaker is Dr. Haripriya Arvind, who is the Chief of Intraocular Lens and Cataract Services at Arvind Eye Hospital. She will be giving a talk on overview of TASS. Over to you, ma'am.
Thank you. Thank you, Dr. Santosh, for having this very important webinar. Are my slides being seen okay?
Yes, Harip.
Yes, doctor.
So just imagine you go into surgery one day and you have an uneventful surgical list. And first day post-op, we see out of 8 cases, 3 patients have severe inflammation. I think any surgeon, any ophthalmologist would be concerned about it. And TASS is something which presents like this. So the toxic anterior segment syndrome is basically inflammation that involves only the anterior segment of the eye. This terminology was first given by Monson in 1992. In many patients, you only see specific corneal endothelial damage, and this is termed as toxic endothelial cell destruction syndrome. If it includes inflammation and hypopyon, it is called as a TASS picture. So typically, TASS is inflammation that occurs within 48 hours of cataract surgery. But I think numerous papers also have a very, the onset can be quite varied. It could be acute within the first few days or delayed even after several months. Most of these patients, they have inflammation only in the anterior segment of the eye, and very few may have some anterior vitritis. They are always gram stain and culture negative, and they improve with steroid treatment. These are the different factors which you see with TASS. On histopathology, what is noted is cellular death, extracellular damage, which results in severe acute inflammatory immune response. Now, the anterior segment inflammation can range from mild to severe, as was said. This could be just a small hypopyon. What is seen typically in most patients is a diffuse corneal edema. This is limbus to limbus, and most patients have this. And severe patients, you may also have a fibrin membrane or a kind of an exudate-like picture either in front of the lens or behind the IOL as well. The good news is TASS is self-limiting in most instances. Corneal endothelial damage is seen in most patients because cornea is the most sensitive tissue in the anterior segment of the eye, which reacts to any of these toxins. And this is the kind of edema one might see. In terms of intraocular pressure, many patients have raised IOP, and this could be between 50 to 60 millimeters. Some of these patients, when they start off, they may have decreased IOP, and this is because of the initial hypotony, which is seen because of the ciliary shutdown. But over the course of time, the patients may have raised IOP. In fact, we have seen a patient who had a high IOP for almost a month, because some of these patients may have permanent trabecular meshwork damage, which leads to ocular hypertension or secondary glaucoma. So this is, again, a typical picture. You may have some hypopyon here, trace or 1 millimeter hypopyon, and diffuse corneal edema. This is the same patient who was treated with topical steroids, and after 5 days, the cornea resolved about 90%. A few DM folds were still seen, but the patient didn't require any intervention. Now, this other patient has more dense membrane. So one can see like an exudate kind of a picture just in front of the lens with the membrane over the pupil going up to the section. This patient underwent an anterior chamber wash. The reason anterior chamber wash was indicated is because this helps to hasten the healing process and also to reduce the incidence of PCO, because many of these patients, if we treat them with just topical steroids, and they may require a much prolonged course of treatment, but more importantly, they may also have some chance of cystoid macular edema or PCO as well, a couple of weeks or months down the line. So this is the same patient after the anterior chamber wash and some medical treatment, the patient resolved quite well. So this, in handling this patient, I think TASS is very important to remember, but one has to remember that any kind of inflammation which is significant, first thought which has to come to our mind is endophthalmitis. So unless we are convinced it is not endophthalmitis, one has to treat the patients like endophthalmitis. So the first goal will be to rule out any infectious etiology. Once that is done, we would start these patients on topical steroids every hour. Also, we'd like to follow up these patients quite closely, just to see if they're not worsening following intense steroid treatment. If so, then you would have to treat the patient more like an endophthalmitis. In severe TASS, we also give these patients some oral prednisolone up to 40 milligram per day based on the severity of the inflammation. Again, considering the systemic condition, because TASS is the only thing one has to remember is the incidence of TASS is higher in patients with, of course, diabetes or hypertension or cardiac illness. So those patients are at a higher risk. Topical NSAIDs may also be added for pain control. And we also add a broad spectrum antibiotic like moxifloxacin, especially because we may not be very clear in some patients with severe inflammation if it is a TASS or endophthalmitis. Follow-up is very critical just to see how these patients respond to treatment. In case the inflammation worsens, one might even consider a repeat culture to look for any endophthalmitis. Endophthalmitis also, these patients may still be culture negative. In fact, currently our endophthalmitis culture positivity is only about 30%. But if these patients also present with culture negative, but more of vitritis and vitreous exudates, we would treat these patients as endophthalmitis. Some patients may require surgical interventions like anterior chamber washout, vitrectomy, or IOL removal. This again depends upon the severity and the surgeon's discretion if the inflammation persists beyond a point. Patients who have very severe corneal damage may require corneal transplantation later. And again, advanced glaucoma may also need any surgical correction, surgical management, along with anti-glaucoma medications. So TASS basically is more in fact, it is limited to the anti-segment of the eye only. It is non-infectious, and the toxic substance causes the inflammation in the anti-segment. Whereas endophthalmitis is across the eye, but more in the posterior segment. In most instances, there may be a live organism which causes the endophthalmitis, even if the culture is negative, and the inflammation can be across the entire ocular cavity. What is the etiology for TASS? This could depend on, anything which goes into the eye could be a risk factor for TASS. And this includes irrigating solutions, ophthalmic instrument contaminants because of poor CSST practices or something you've changed in your aseptic protocols, ocular medications, or intraocular lenses. So irrigating solutions, they can contribute to TASS either because of altered chemical composition, incorrect pH or osmolality or preservatives. When coming to CSST, what is important is that some detergent residues can cause a TASS-like picture. If you don't wash off these enzymes well, this can cause TASS. And any metal ion residues or denatured OVDs which are stuck in the cannula can also cause TASS. Ocular medications, anything which go into the eye, including intracameral epinephrine, lignocaine, antibiotic, pilocarpine, any of this, one has to ensure that the pH and osmolality is correct. And it will be good to test each batch when using these intraocular medications. And IOLs, the commonly published reasons are the polishing compounds, especially aluminum, or if there's issue with cleaning and sterilization compounds. So this is the list of publications in terms of the case reports on TASS over the last decade. And as you can see, there are a significant number of publications on, on IOLs. So 3 of these reports are on IOL, and this is 2015, 2016, 2000 in ophthalmology and in JCRS. And the common factor is that they are all hydrophobic IOLs in these publications, but hydrophilic lenses also with TASS has been reported. And the other causes could be contamination of the autoclave reservoirs, BSS, generic trypan blue could be a cause. So we have two papers where trypan blue was the cause for the TASS picture. ETO sterilization could be an issue, or intracameral gentamicin overdose. These are the different large seeds which were reported. And if you look at the clinical picture, just looking at these three publications, the paper by Suzuki et al. And Oshika looks at TASS, which was caused because of IOLs. And the EVS study obviously looks at endophthalmitis patients. And the clinical picture in these two groups, if you compare, one thing, the onset actually, there is no specific pattern. So with TASS as well, you could have a delayed onset, especially if it's linked to the IOL. In patients with endophthalmitis, there's a higher chance the patients may have more pain, blurred vision, and lid swelling. It was not actually reported in these two papers as much. Chemosis, again, could be more in endophthalmitis, whereas the anti-tumor inflammation could be more in the TASS picture. And media opacity, again, is more common with the EVS study. There are different papers which talk about different outbreaks of TASS. I think the whole world started getting more interested in TASS once there was an outbreak of TASS in the US. So this was reported in 2005 because multiple surgical centers in the US reported TASS. A total of 112 patients were reported to have TASS. And the cause for this was because they used BSS. So that was the factor which caused this inflammation. And this was manufactured by Cytosol Laboratories. And I think of 14 BSS lots, 5 had excess endotoxin limit of more than 0.5. At that point in time, 0.5 was the cutoff for the endotoxin limit. Today, it's about 0.2 EU per ml. So irrigating solution, as we know, could be one major cause why TASS outbreak can happen. The other very important factor is water. So this is an interesting paper out of one city, which had 3 surgeons at 2 different facilities in 2002. And it was found that the water had higher sulfate quantity. And this was because the water which came in from the metropolitan water had a different way of flushing and cleaning. So earlier it was done every week, but once it was changed to once every 4 to 8 weeks, the water quality changed. And this was the cause for the TASS outbreak. So just imagine what a lot of homework this team must have done to actually identify that the water and the change in the steam generator, which was, which had the water from the city's supply, caused the outbreak. The different other causes, again, a very important factor is sterilization. So various enzymatic and non-enzymatic detergents can also cause TASS. And why does this happen? Because when you have endotoxins, we find that these enzymes especially, they don't deactivate at the normal autoclave temperature of 120 or 130 degrees. They need temperature of over 140 degrees centigrade. That is why these enzymes and these ingredients are still retained, and that is what causes this inflammation post-op. So the most effective way to remove these enzymes or detergents is to flush these instruments well. So after you clean them with whatever agents one uses, first of all, it's important to minimize these agents as much as possible. But when these are used, you'll have to wash them well with sterile deionized water and then send it out for autoclave. This is a more recent paper by Nick Mammelis. So the first, I think 2005, 2006, there was numerous papers which came out of Moran, and Nick Mammelis was the head of the cataract, the TASS task force at that point in time. In 2012, he analyzed the outbreaks which happened between 2007 and 2011 in the US. And the common factors were inadequate flushing of the instruments, use of enzymatic cleaners and detergents, use of reusable cannulas, and reuse of single-use devices, blades, tips, sleeves, etc. So if one has to reuse any single-use device, one has to be very careful to ensure we're following the right protocol, including number of times it has to be used, how would one clean it, etc. And the other issue could be that, when you're reusing the tips, IA tips or phaco tips, the OVD material could also be stuck within the cannula. So one has to be sure to flush out this with adequate amount of fluid before sending it in for sterilization. Now, this is another aspect which was explained by Werner et al., where very interesting that 8 patients had post-operative TASS because of steroid ointment. So these patients basically had an ointment which was used after surgery. It was antibiotic steroid combination ointment. And post-op, they found that over the IOL surface, there were various globules. And once this was tested, they found the same vehicle of the ointment was there on these IOLs as well. So this could also be a reason because anything on the surface could also ingress and cause TASS. Ultrasound water baths could also be a source because you find that these ultrasound water baths could actually be a good place where the gram-negative bacteria grow, like Klebsiella or Pseudomonas, and this could lead to buildup of endotoxins. Now, endotoxins actually are a very important cause why TASS outbreak can happen. And this happens because of contamination of instruments during sterilization, either from the water bath, ultrasound bath, or autoclave reservoirs. So what happens is normally when the gram-negative bacteria are destroyed during the regular autoclave process, but what may stay back is the lipopolysaccharide. So this lipopolysaccharide endotoxin from the gram-negative bacteria cell wall may attach to the instrument as deposit and cause the TASS picture. So difference between exotoxin and endotoxin. So endotoxin, we know a lot about endotoxin. The exotoxin, as we know, is something which the microbe secretes, and this is a viable microbe. Now, most of the time, if you have the right process of autoclave, this is actually taken care of, but the endotoxin is what may remain because the bacterial cell wall may cause the endotoxin to retain, and this may cause the inflammation. So the FDA in 2014 changed the endotoxin limit from 0.5 to 0.2. So today the prescribed limit for EU per device is less than or equal to 0.2. And this implies to all in everything which goes into the anterior segment, including the IOLs, iris reconstruction lenses, or the capsular tension lens. So any of this, if you test, the EU has to be less than 0.02, which is what the manufacturer would do before they pass the product for packing and dispensing. The other different aspects of going on to the aspect about lenses, because currently I think we are looking at the possibility of an IOL causing this issue of TASS, which we see in our country today. There are various reports in the literature. So this is one where 251 patients who had the Hoya Actisoft lens had TASS. This was in IJO 2015, and this was in different hospitals. Interestingly, most publications on TASS with IOLs have come out of Japan, and all these papers have been from Japan. We don't know if the other countries haven't reported or if there's something else different there, but most of these papers are from Japan. The other paper also the same time in 2015, again was from Japan, again with the similar lens. And this third paper on the hydrophobic lenses causing TASS was published in 2016 by Oshika et al. And they used either Resto or Resto toric IOLs. About 147 patients had TASS.
Ma'am, just a request for the time slot, please.
I'm going to wind up soon. And this, and the manufacturer basically said that the aluminum in many of these patients was higher, and this could have been the reason for the TASS. We also had 2 reports on hydrophilic lens. One was with the memory lens, and here the compound was the aluminum which caused it. And the other was from the lentis comfort lens, which was just last year. So both these lenses also we have had reports of TASS. So in conclusion, I think it's important to have a thorough protocol for cleaning. There are 2 things I would recommend the audience to read. One is the paper by Seth Gupta et al. From Arvind Pondicherry, who talk about the protocol for determining the etiology of TASS. So one can go through that list. So if someone does have an issue with TASS, one can look at all these different points to ensure that they can identify what the cause is. The second is published in BMC Ophthalmology 2018, which gives a sample algorithm for prevention and investigation of TASS. So once a TASS happens, how does one actually address the issue? So in conclusion, it's important to have a team effort, written down protocols, and the entire team should be well versed with the norms. And I think periodic review of data is also very important to ensure we have this at check. Thank you.
Thank you very much, Dr. Haripriya. That is such an excellent overview, and everything was so lucid. I think because of the interest of time, in terms of discussion, I would like to invite 2 of our esteemed panelists. The first one, the point that you made, which is very clear, that if you have a patient who has severe corneal edema, the picture that you had shown, that it becomes a little bit more easy to diagnose that the patient has TASS. But if you have a patient who comes in with the hypopyon kind of an increased inflammation, then there you might suspect that there is endophthalmitis as well. So my question is for Dr. Ritu Arora first. Professor Arora, I think everyone knows is a cornea specialist of many years experience, excellent surgeon from Guru Nanak Eye Center. So have you seen cases, do you think that there's a difference in the etiology when you think about the endotoxin related to TASS creating corneal edema versus all the other entire causes of TASS?
Yeah, definitely. Whenever I see endotoxin related, I mean, you do get very severe corneal edema, limbus to limbus. But my point here is that we also had an outbreak of TASS maybe 2 months back. And the problem is, suppose on the day 1, you have a patient who has a very severe reaction and maybe very minimal hypopyon. How do we know we are dealing with TASS or we're dealing with endophthalmitis? That is my major issue. And that's what our hospital went through, and a lot of residents used to have those kind of cases. And I would like to also interact with other panelists also, that how to go about it when you get a case in that situation. See, here we are dealing with the problem. We know it's a confirmed TASS, but I am taking a retrograde step that when you have a patient like this, how do we know we are dealing with TASS or we are dealing with endophthalmitis?
I think the next 2 talks are going to deal with that. So we will go on to the next 2 talks. Before we go on to that, just one more panelist I'd like to invite and ask a question. That is Dr. Lalita. I'm not sure if you've logged in yet.
Ma'am, she won't be joining today, ma'am.
Oh, okay, fine. In that case, if I have any other panelists chip in. We had a comment from someone.
My only comment to the entire talk, very well delivered talk and very illuminating. Unfortunately, doctors are not involved in all these processes. You see, I would like to make it mandatory as a part of curriculum somewhere. This is not for today's lecture, but for an ongoing exercise that doctors should be involved, like a first year PG, second year, third year PG, could be posted in the sterilization room to see what's happening, how things are packed, how, all this autoclave, ETOs. Because if you take today's modern ophthalmic surgeon, he's not aware of a lot of these things. So, and we are dependent on technicians and other things.
That is one part of it, Dr. Lalit, that residents should be exposed to all that CSSD procedures. But my major question with the products which we are getting. How do we make sure all the products?
The reason I was saying so, Ritu, was that doctors get caught in medical legal hassles.
True.
They are made to pay through their nose, as Mahipal was telling the other day. And there sometimes you see put behind the bars, the media is blazed for no fault of doctor in that case. See, doctors are not involved in manufacturing of all these IOLs, cleansing, ultrasonic baths, and ionic solutions. So the answer I'm coming to your question about how to distinguish, that is a separate clinicians category. That I think subsequent talks will tell us what you were asking. But to the lawmakers, I think we should put in after this, webinar is finished, that from AIO's side, that there should be proposal that you see in the entire curriculum, whosoever you are, you have been a teacher and a dean, that this should be enforced as a compulsory posting of the PGs into that lab.
I have one question to the panelists. Why is it that there's an outbreak of TASS? Only some of them are having the clinical features and others are escaping it. Is it because there is an altered immune status in some of these people? Are they diabetics, or specifically the blood aqueous barrier is affected in only some of them, so they get the TASS? If it is a TASS outbreak, shouldn't all the patients be getting it at that time?
No, Chitra, the thing is, there because Haripriya showed there's so many variables in TASS.
Yeah.
Anything which goes inside can cause TASS. So
Yeah,
because I came across one, from Chitrakoot, they have also been using 6,000 IOLs, but they haven't got a single case of TASS. You see, the etiology is so variable because they have been washing. So maybe some people are not washing these IOLs. You see, because the implicating factors are so many. So therefore, you can't come to one conclusion that why some people are getting and why some people are not getting.
I think we can just move on to the next three talks, which are by esteemed guests, by the esteemed speakers. The next talk is by Dr. Vishali Gupta, who is going to talk about how to differentiate endophthalmitis from TASS. So over to you, Dr. Vishali Gupta. Everybody knows that she is
Thank you. Thank you so much, Ella, Santosh, and great initiative. Continuing with what the questions have been raised in the panel, so my talk is going to be about how do you approach a patient on the first post-op day when you are kind of confused between TASS and endo. Well, we all hate to see this in our patients in the post-op or post-injection for that matter. And the moment we see it, we all love to believe that our patients have sterile inflammation and it's not infective and it is TASS. And the question that Dr. Ritu very elegantly raised is, fine, it's TASS, and we know we are dealing with the tsunami of TASS. But we also have to remember that in between, in this tsunami of TASS, we would have some clusters of endophthalmitis also. So how do we go about differentiating between the two? I don't think I have to spend too much time because it has been very well discussed already. I would just go on to very key points. Like to me, if the patient has pain, if the patient has lead edema, and if it's kind of occurring in 3 to 7 days most of the times, with severe reduction in the visual acuity and the corneal edema, which is not limbus to limbus, looking at the fundus is of utmost importance. And if the fundus is either showing a yellow glow, or if I can't see the glow, then the exudates on B scan. Now, these are the features which are very, very typical of endophthalmitis. And I don't think I have to read it out to this August gathering because everybody kind of is taught of these differences in our PG course. Practically, however, the things are a bit different, and this is just to show the classic difference when we see it 24 hours after cataract surgery, 624, no pain, no swelling, limbus to limbus edema, anechoic, this is TASS. And when I see a picture like this is endo. But that's truly not a real life. The real life is very different. And Haripriya has shown beautifully that many times the drug themselves could be a cause of this. For example, this lady, the top panel shows she's a patient with intermediate uveitis and has been receiving injection of some drug, which I'm not going to name. Now, post the injection, my fellow says, well, within a couple of hours of giving injection, the patient complained of decreased vision. From 618, she was down to counting finger. And he says, oh, I see all the exudates in the vitreous cavity. Well, if you look at this situation, this is not, you don't expect that you have done an intervention and within 3-4 hours of the intervention, the vision has gone down and the exudates have formed and all this. So this is what are the drug deposits, and you may call it a sterile endophthalmitis, non-infective, are drug-induced, but many of the drugs themselves can precipitate and produce this kind of a scenario. So these are kind of the things you would keep in mind while diagnosis. Now coming to our basic topic that when you are looking at it, you are suspecting infection, you want to believe it is TASS, believe me, but still, whenever in doubt, whenever you are not sure, it's always a good idea. Even if it is TASS, does not matter. Get the sample, do the smears, do the culture, and Malditoff is one which I'm going to show you how it helped us, but we find it extremely useful. Molecular diagnostics, because they are going to tell you which way are you moving, endo or exotoxins. So when do you plan to look for these sampling, cultures, and all these? Whenever in doubt. Whenever there is worsening of inflammation on steroids, and by steroids, I don't mean that you keep on trying steroids for days, like it should be like in 24 hours, even if you want to believe it is TASS and your patient is not responding to steroids, move on to cultures and smears and diagnostics. Whenever the features are not very classic, they are, neither here nor there, it's a good idea to sample. So whenever you are in doubt, as Dr. Haripriya mentioned already, always are on the side of infection. I'm just going to show you our experience, like my personal experience of managing such kind of a scenario when unfortunately we had Avastin-induced endophthalmitis, or infection. So, we had used Avastin using all aseptic precautions. And since we do not have aliquot, so at that particular point of time, we used to open a vial of Avastin and inject all the patients in the main. So 24 hours after injection, only 2 of all the patients that had received, they presented with watering, very mild decreased vision, and they came within 24 hours. The rest of the patient were not even symptomatic, and we subsequently called them for examination. So the first step is that when you see a patient, even if 1 or 2 of them have reported, the first step is to call all the patients back, because you want to examine them, even if they may not be symptomatic. We, of course, put a very high alert and emergency duties, and we call our 30 patients who had received injection the previous day. Though, I will tell you many times, there were mixed opinion. Some people said we should not blow it up. If the patients are not coming, don't call them the same day, segregate. But I think whatever the problem is, you should face it with your heads high. So we immediately canceled all the Avastin on that day and for future. So if we are facing a problem, I think these are some of the actions which we learned and which I would like to share with you all, how we managed. Of course, the initial thought was TASS. So we contacted our microbiologist to give us the report of the residual sample of the Avastin, which was sent for culture the previous day. So they did a smart thing. They just took the solution and got the maldate off from the solution. And within 3 hours, they informed us that it was already showing the turbidity in the culture. And they did not wait for the culture to grow because it takes about 48 hours. They simply took the solution and did the sensitivity. But before we got this sensitivity report and all, we had injected at least those 2 patients, Venko and Septa, who presented, because depending on our microbiologist report, we knew it was the organism we were dealing with, though clinically it appeared like TASS to us. So by the same evening, we could call back 11 patients. We started IV antibiotics. We, made the whatever arrangements available. And the microbiologist, as I mentioned, used Malditov to directly give us the culture report from the culture fluid without waiting for the growth of the culture. So by 7 p.m., they said that culture is showing the organism which is sensitive to ceftolivocotrimexazole. So cotrimexazole was actually very good because Septron is so affordable and so cheap. So some patients, when we talk of these symptoms, the vision loss was actually not seen in many. There was very mild complaints and majority of them were asymptomatic, and they came only because we told them to come. And believe me, there was reluctance on part of the patients just to come back. But we could get them 24 patients within 48 hours of injection. 4 of them actually came late. So when we look at the presentation is that of the 28 eyes, 12 presented with features of corneal edema, raised intraocular pressure, and predominantly anterior segment inflammation. And they were just like TASS, like we have been shown and discussed beautifully. Whereas 16 eyes of the same group had clear cornea, hypopyon, severe vitritis, and a yellow glow. And this is just to show the picture which was TASS-like. About like 42% of the eyes had fibrinous reaction, hypopyon, high IOP, corneal edema, and the posterior segment was anechoic on ultrasound. Wherever we could see there were no exudates in the posterior segment. But this was not TASS. This was endophthalmitis, which was culture proven. And then we had another set of 58% of the eyes who had minimal corneal edema, normal intraocular pressure, and the features of large hypopyon, severe vitritis, and poor media clarity. So, same culprit, but 2 different manifestations. So we did treat them as endophthalmitis, and we did whatever is required for the endophthalmitis. We did a lot of vitrectomies, PPVs with intravitreal, but maybe because our threshold for doing vitrectomy was very low. But eventually we realized the eyes where we had intervened very early and aggressively did far better in terms of visual outcome, though we saved all the eyes. So this is the final visual acuity and everything. And this is just to show you how this was pre-injection, and 1 day before injection, you ended up with the picture, 26 IOP, fibrin, and I thought it was TASS. But then we believed our microbiologist and we treated it as endophthalmitis, and these are the patients. They grow this funny organism, Streptomonas maltophilia, which was subsequently proven on culture, but we had managed it just before we got the culture based on Malditov. And this is still another example which presented more of an end-of-like picture. And this is post-response to IV antibiotics and vitrectomy. So the microbiologic profile was 11 eyes showed gram staining for gram-negative bacilli, 7 showed culture positive, 4 Strenophonas, whatever it is, maltophilia, and 6 out of the 7 culture positive actually had hypopyon and vitritis, and one was positive on PCR. So I'm not going to get into the details of all this. We published all the details in IJO, but the moral of, and of course, we published the editorial in IJO about the counterfeit Avastin in India, and we, like with the part of AIOS and BRSI, we did go to Drug Controller of India. There was a lot of story behind this epidemic we had, but for the purpose of this talk, I would like to conclude that it's extremely important to differentiate between infective versus non-infective endophthalmitis, especially in situations like this where the entire country is facing TASS. We might be having the small little clusters of endophthalmitis, and we should not get swept in that tsunami that everything is TASS, because if it is TASS, if you mistake TASS for endophthalmitis, you will not lose the eyes. But if you mistake endophthalmitis for TASS and continue to believe it is TASS, then it might cost very heavily on you. So my only message is, I would reiterate what Dr. Haripriya said so beautifully, that whenever in doubt, it's better to err on the side of infection. And with this, I would like to thank once again to all of you for the kind opportunity.
Thank you so much, Dr. Vishali. As usual, an outstanding presentation and so clear about the case series that you had and how you investigated. It's very, very fascinating. And it's so relevant for today. Dr. Ritu, I'm not sure if that answered your question.
Dr. Somshila, see, I am again going on a different thing. I would like to know, when people are saying TASS, what are the symptoms they are having in the patients? You know, that's one thing I would like to know. You know, see, I can just share that what we had at our center, most of the patients had unexplained severe fibrinous reaction.
Right. I can tell you about the responses. We've received 21 responses at AIOS headquarters from the people who had TASS, and their symptoms mainly are that there was hardly any pain, corneal edema is there, fibrinoid reaction is there, and AC flare cells are there. So this is the most common thing. Most of them, in fact, have responded within 3 to 5 days. Some of them are severe, taken 7 to 10 days to respond, but none of the eyes, as per the data that we have, none of the eyes have been lost. I don't know, because not everybody would have, given us the data, but whatever the data we have of the 21 responses.
No,
Namrata,
see,
can you show that PowerPoint presentation? Because we made yesterday about the 20 patient response we received, because pictorially that will depict what Ritu is asking about the presentation.
What
in this particular episode, what countries
it's in the last 2 months, So we did not have that much of corneal edema.
So
just had unexplained increased AC reaction, some fibrinous reaction.
So we analyzed these 20 responses. So let's show that responses, Namrata, in case you can.
In other words, can we say what we're having is not really TASS as in toxic anterior segment syndrome, where we have corneal edema, later on we have a membrane on the cornea, and we have iris atrophic changes. That is TASS.
Yes,
what we're having
classical TASS. Yes.
Is post-operative sterile inflammation.
Right.
So PSI or something like that.
Yes. So, I mean, not at least what we had at our center, there were quite a few.
Yeah.
And
sorry, Dr. Harbansal, I interrupted you. Please go ahead.
No, actually, very important for us is very simple, because we do topical phaco. So most of the patients do come, I was seeing perfectly all right till evening. And in the morning they get up and they are not seeing very clearly. So most of the time the complaint is the diminution of vision from the previous evening. So that is what. And then I think this is a very valid point, what we should call TASS only when there is a corneal edema or any severe inflammation with the fibrinous exudate should be called TASS. So that we have got to define which what to level. I mean, if there is only severe inflammation and some fibrinous exudates going into the incision site from the pupil side, very web-like structures forming over there, which is very quite common as compared to having the severe full-blown TASS.
Yes, this is what I was coming to. This is what I was coming to.
Even patients without corneal edema, I would still classify them as TASS. If there was like no other inciting factor, there is no other intraoperative reason. If the patient had a uveitic cataract or a complication or phacolytic, all then their inflammation is fine. But if everything was uneventful and the patient has some inflammation, either immediate post-op or they come back in a few days, it could be sporadic, but more commonly as a cluster, then I would think it would be a TASS kind of a picture.
I think Professor Lahane also had something to say, and then Dr.
See, what I see in JJ, we are operating near about 100 cases every day. We have not come across TASS a single patient. That maybe got skipped, but we are getting patient from all over Maharashtra, also outside Maharashtra, and up till now we have crossed 57 patients. In the morning today, we have got 6 patients. 3 are endophthalmitis pseudomonas operated in the morning on Saturday, and 3 are having the TASS. But I am considering that maybe the because those are operated in the afternoon. 3 cases. This veterinary surgeon is thinking this is a TASS, but I am again thinking the same thing is used in the afternoon also. But number of the TASS, yes, it is not required that there should be a corneal edema, but yes, in few patients there is a corneal edema also. But fibrinous reaction, reduction in the vision. Patients are coming in 24 hours, or you can say 48 hours, or they are coming up to 7 days, 8 days, 10 days. Now patients from, you can say, the Buldana or from the districts which are away from Mumbai, they are coming after 15 days also. And that time it is very difficult. What I have seen, when they have given steroid, if they are not responding, we have taken them on the operation theater. What I have observed in 2 patients, the membrane is not separable from the capsule. It means the whatever the bag. So I am trying everything, separating the central area, but the bag is not getting separated from the, you can say, the lens. And if I will go inside by, you can say, dialer or anything, the total bag is moving. So such type of very fibrinous reaction is seen in 2 patients. They were taken on the table, those who were not responding for the steroid. But the maximum patients are responding for the steroids. Up till now, out of 57, we have got 6 endophthalmitis and 51 TASS patients in JJ. Out of 51, everybody has got vision, and 2 patients, their vision is less. I don't know what is the reason for that. But endophthalmitis, 3 patients were not treatable. We did the keratoplasty and everything, but we could not save the eyes. Other 3 patients are responding. So this is what.
So just again, in the interest of time, we'll quickly go on to the next presentation. And after Partho, I request the panelists to be ready for his at the end of his talk. Especially Dr. Schwartz, I'd probably take some comments from you after Partho's talks. Partho's, as usual, with his very nice slides. Partho, your slides are visible.
So Somshila, I would also like to share the data, as Dr. Lalit Verma sir was saying at the AIOS, that we have collected already for our cases from our members for this outbreak of TASS. Okay.
Sure, you want to do it now or
whenever.
Okay. So maybe because we're still with the sort of the differential diagnosis of TASS, so it'll be nice to keep in this flow if it's possible. So we have Partho going in next, and then Dr. Schwartz comes in. So after that, we can for sure go to, do you think that's fine, Dr. Namrata?
That's okay.
All right. Partho, all yours. And you're going to talk about TASS versus uveitis, obviously.
So thanks to Dr. Santosh Sonawar and team IJO for organizing this important webinar. I'll try to give a different perspective of post-surgical inflammation for the practicing ophthalmologist and the postgraduates. So my approach will also address the isolated cases of post-surgical inflammation we encountered in our clinic. So I don't have any financial interest in any of the product discussed in this presentation. So there are primarily 2 types of inflammatory reaction we encounter after a successful cataract surgery. The first one is often subclinical and considered normal. Even an uncomplicated intraocular surgery in the normal eye can cause mild iatrogenic iritis during the first few post-operative days. Now, depending on the duration of the procedure, the amount of the intraocular tissue manipulation, the blood aqueous barrier is disturbed with the consequent exudation of the serum proteins and the cells from the blood into the anterior chamber. So the second one is always unexpected and pathological, the severe fibrinous reaction or hypopian uveitis following uneventful cataract surgery, and it is major concern and needs rapid and effective management. Now the major challenge remains identifying the TASS at the earliest and differentiate it from endophthalmitis and definitely the uveitis or post-surgical inflammation. Now, it has been exactly 30 years since the Monson and his colleague coined the term toxic TASS, the toxic anterior segment syndrome in 1992, but still this entity remains an enigma. Now, is it possible to differentiate between TASS, uveitis, and endophthalmitis? The common myth is the TASS usually appears 12 to 48 hours post-operatively, whereas the endophthalmitis appears 4 to 7 days after the surgery. Now, here is a study of 251 cases of late onset TASS caused by the IOLs that had become contaminated with the heavy metal like aluminium due to a damaged instrument used in the IOL factory while manufacturing these IOLs. Now, if you see the mean time from the IOL implantation to development of the first symptom was more than a month. Now, you can imagine it is so difficult, and this is also to bring to the notice that it's not in coming days we may get a lot of new cases of TASS. So now look at the sets of the clinical signs in these patients: the inflammatory cells, conjunctival injection, keratic precipitates, fibrinous inflammation. It is impossible to differentiate only based on the clinical signs. Now let's move ahead. Now here is another table from a review that compared the two large-scale outbreak studies on TASS with the endophthalmitis vitrectomy study. A similar comparison is not possible with uveitis because it is a large group of heterogeneous clinical entity and can have plethora of manifestation. Also look carefully at the symptoms and signs here. So uveitis can manifest as any of these clinical signs and symptoms mentioned in this table. So this takes us back to this gentleman and his classification. Almost we have forgotten the Duke-Elders classification. Perhaps TASS represents an example of the toxic uveitis. Now, so cells, flare, congestion, fibrin, hypopian, anything else that can differentiate TASS from an otherwise post-surgical inflammation? Here is an interesting animal model study from the Korea that has been tried to compare the clinical findings and aqueous levels of inflammatory mediators between TASS and endotoxin-induced uveitis. Now, two animal models, the TASS and uveitis, were established. Each animal model was divided into two groups according to whether the rats were pre-treated with systemic dexamethasone or not. Now, after that, they established that animal model for TASS with a diluted solution of orthophthalendihyde, and they injected that lipopolysaccharide to establish an animal uveitis model. Now, when they compared between these two groups, they found that the corneal haze scores were significantly higher in the TASS group than the uveitis group. But the clinical scores for anterior uveitis, that means the cell counts were same between them. Now, coming to the aqueous marker, the aqueous levels where prostaglandin 2 was significantly higher in the TASS group. And also they found that the pre-treatment group with the dexamethasone proved to be helpful as it inhibited the increase in the aqueous level of both prostaglandin and TNF-alpha. Now, there was no significant difference in the cell counts between the TASS and the uveitis group. Even the aqueous humor cytology was exactly similar. the polymorphonuclear neutrophils followed by the lymphocytes and the monocytes. Thus, the corneal haze emerged as a very important factor in differentiating TASS from this animal model study. So now the TASS can be a breakdown of the ocular blood-ocular barrier with a damage to the corneal endothelium. Now the severe breakdown of this ocular barrier can happen, and there may be various exogens described widely in the literature and described by the previous speakers. I'm not going into the details of them, but I want to highlight a single point here. I think not always these exogens are chemicals. All of us are familiar with this product, the gigazyme, or take any enzymatic detergents which are being used to clean the sharp instruments in our OT. Now, this main component of this solution is that responsible for TASS is substilicin. Now, this substilicin causes ultrastructural damage to the corneal endothelial cells, break down the tight junction between the endothelial cells, causing a marked inflammatory response, corneal edema, and if not treated earlier can lead to corneal decompensation also. Now, this substilicin is not a chemical. It is a protease initially derived from the Bacillus subtilis. Now, some individuals are known to be allergic to this substilicin. Not only the eye, substilicin is known to cause enzymatic detergent asthma, not to all, to specific individuals. So it is not necessary that all patients will get similar kind of allergic reaction to the similar component in TASS. Now, it is very important to rule out the other causes of inflammation. One of the best way when you are dealing with such patient, take a proper history. As William Osler said, listen to your patient, he is telling you the diagnosis. Often a patient may give you a valuable clue about the inflammation that has been missed earlier in a busy routine clinic. In presence of such history of past uveitis, one should go through these old documents and try to start the aggressive treatment, preferably with systemic steroid, and monitor the patient very, very closely. There are a lot of systemic factors actually often associated with TASS also. I'm not going into the details. Now, once you have taken a proper reliable history, you must look carefully for the crystalline lens fragment. These lens proteins behave as autoantigen outside the lens capsule and can cause significant reaction. So such inflammation can occur as early as 2 weeks to 1 year later. And if not carefully looked for, this may miss, especially in patients with the dark arcus annulens. Now, this retinal lens fragment can be seen after uveitic or complicated cataract, after phacoemulsification, even after small pupil, with especially when someone is using hooks, because the small fragments can be hidden under the tented iris pulls by these hooks. So unexplained chronic anterior uveitis, sometimes you may need to perform a gonioscopy, because gonioscopy can give you a view that the small fragment is there. So this is all about just ruling out the other inflammation when you are suspecting the TASS. Side by side, you have to do that. So as we know, the mechanical iritis can present when the single piece IOL is placed in the sulcus. All of us, we know that. I'll show you a case where a 62-year-old female, when we examined, the lens was in the sulcus and the patient presented with typical uveitis picture. There was, we tried to rule out endophthalmitis also. The PCR for the SQS aspirate was negative. Now then, when we try to do a UVM, I'm sorry for this bad quality of UVM picture, but you can see here that UVM helped us to understand that though the lens was in the back, but because of the eccentric capsular rhexis, the IOL optic was rubbing the posterior surface of the lens, and that's how it was leading to a mechanical iritis and causing significant inflammation. So this we have come across some few more cases where the lens is IOL is inside the bag and causing chronic mechanical iritis. So before you jump into the diagnosis of this TASS or any other post-surgical inflammation, you have to rule out this. So this is just to show that how the inflammatory reaction can happen against the IOL. This is one patient where the cellular deposits were there. And when we explanted the lens, the histopathology showed that the explanted IOL showing numerous histiocytic cells on the surface of the cells and various giant cells on the haptic of this silicon plate IOL. Now, you will get a clear picture from the here how aggressive the inflammatory cells can act. This is a picture we have taken with the help of the scanning electron microscope. You can see this inflammatory cells trying to enter inside this IOL surface, and you can see from this image very clearly. So just finishing, just my few tips to the general ophthalmologists who will be watching this webinar. As always, steroid remains the mainstay of the treatment for uveitis and TASS. One should be aware that the typical signs of TASS can be masked by the strong topical steroid during the early postoperative period. Thus, in some cases, TASS can manifest after discontinuation of the topical steroid, and you often see the patient coming with a uveitis after they have stopped the topical steroid. And also, there are certain situations where chronic post-surgical inflammation can be tackled with the help of this immunosuppressives also. We have 3 cases which we are managing with that. Now, you have to be very careful while managing such cases, because you have to rule out, as the previous speaker said, that you have to rule out the endophthalmitis and other infection. Just to last 2 slides to highlight the topical steroid, that you have to remember that although the suspensions are preferred, they need more patient compliance. When you are treating a case of post-surgical inflammation, you have to explain the patient that they need to shake this bottle before use. And one should be judiciously choose between the topical steroid, because we know that the corneal stroma is hydrophilic and the epithelium is lipophilic. So that's why the topical steroid with acetate moieties can penetrate better. And perhaps that's the reason that dexamethasone is 6 times stronger than the prednisolone on molar basis, but still prednisolone acetate attains 20 times higher concentration in anterior chamber than the dexamethasone phosphate when applied topically. So just to conclude this presentation, you have to think about the post-surgical intraocular inflammation, divide it into acute and chronic, and you have to understand that the post-surgical inflammation remains an entity based on the diagnosis of occlusion. One needs to have a high index of suspicion and exclude the infectious etiology first, and one that is done, then step by step, you can rule out the other entities. Thank you.
Thank you, Partha, for bringing out the differences between post-op uveitis versus TASS or inflammation, sterile inflammation, so clearly. Can we quickly move on to our guest speaker first, and then we'll come back to discussing both Partha's talk and then Dr. Namrata's presentation. So Dr. Schwartz is our guest speaker for this evening, and he is a professor of clinical ophthalmology and medical director at Bascom Palmer Eye Institute. And he has several publications in retina and vitreous sciences in PubMed, and he has several named awards to his credit. And we are quite fortunate that he's part of this meeting and is going to talk to us more about TASS and endophthalmitis.
All right, well, thank you. I'll share the screen. Here we go. All right, good. Everybody see the screen?
Yes, we can.
The title screen. Okay, so that's good. So the title first of all, thank you for inviting me. It's really been very good so far. I'm learning a lot. The title I was given was How Can I Prevent TASS? An Evidence-Based Update of TASS Prophylaxis. I'm going to quibble just a little bit. I'm not sure you can prevent TASS. So I think that really should be our first point here. I have no disclosures, even though I will mention some commercial products. In the U.S., we say, and I think this is true everywhere, that endophthalmitis is not a never event, right? There are events that never should happen, but endophthalmitis is not one of them. You can do everything correct as the surgeon, and your patient might still have endophthalmitis. And I think I would put TASS in that same category. The fact that a patient or a cluster of patients develops TASS doesn't mean that you as the surgeon necessarily did something wrong. And I think it's important that we all understand that and communicate that. And as we know, TASS is typically an inflammatory response to some non-infectious substance that's introduced into the eye during the surgery, in some cases immediately after the surgery. And the number of substances that can do this is vast. Sometimes the cause is never actually identified. But even if TASS can't be prevented, we can work to reduce the number of cases. We can reduce the incidence by following certain peer-reviewed practices. Obviously, proper cleaning and sterilization remain very, very important. Always follow the manufacturer directions. It's always fun to get a new device, but then nobody ever really wants to read the instruction manual. And I think when you're presented with a TASS outbreak in your center, the first question you have to ask yourself is, did we change anything? Are we doing anything differently? Are we using a different solution? Are we adding something that we never used to use? So, everybody else has covered this, but here is the best clinical example of TASS that I could find. So this limbus to limbus corneal edema with decimatous folds. The corneal edema is very far out of proportion to the degree of intraocular inflammation. You'll see the pupil dilates relatively well. There are no posterior synechia. There's no fibrin. There's no hypopyon. And really, the rest of the eye looks pretty good too. There's only relatively mild conjunctival injection. There's no discharge. There's no lid edema. So it really doesn't look like endophthalmitis in the classical sense. And this is a slit lamp magnified image of the same patient. This patient does have a 3 to 4 plus cellular reaction, but really not what you might consider a plasmoid aqueous, and certainly no hypopyon or fibrin. And that's really typical for TASS rather than endophthalmitis. Usually presents the first postoperative day. It can be within 6 hours. Again, the corneal edema is limbus to limbus and out of proportion to the other findings. There may be moderate to severe anterior chamber cells, but usually no hypopyon or fibrin. And again, it may present in clusters. Usually endophthalmitis does not present in clusters. And I think we've had a few excellent talks about distinguishing TASS from endophthalmitis, but again, TASS generally presents earlier and generally the findings are less severe. There can be some overlap here. Interestingly, right, the doctors who do intravitreal injections, we don't call it TASS, but we have something that's very similar to TASS. We have a non-infectious inflammation to intravitreal anti-VEGF drugs, and that might be a reaction to the vehicle or perhaps something in the syringe or the needle. And we have a very similar table that we use to differentiate non-infectious inflammation from infectious endophthalmitis. And really, if you had that table compared to this table with intravitreal injections, everything is the same with the one important exception that with intravitreal injections, the non-infectious inflammation usually presents later than the infections. So the infections after intravitreal injections can present usually within 24 to 48 hours, whereas typically the non-infectious inflammations after intravitreal injections present 5, 6, 7 days later. Although again, there's tremendous overlap, but I only bring this up not to confuse the issue, but I bring this up as an emphasis that acute onset endophthalmitis after cataract surgery really is a different entity than endophthalmitis after an intravitreal injection. But just to emphasize, again, TASS compared to infectious endophthalmitis after cataract surgery usually presents earlier, and usually the signs and symptoms are relatively less severe. And again, here's a classic TASS image on the left and a classic acute onset postoperative endophthalmitis image on the right. And again, the endophthalmitis patient has a prominent hypopyon. The conjunctival injection is much worse. Interestingly, the cornea is clearer, so you can see the intraocular details better, and the pupil didn't dilate as well. All right, so there are many, many, many factors that can contribute to TASS. We're going to break them down. The first is surgical or intraoperative factors. So if your patient had more than the usual amount of surgical trauma, that might contribute to TASS. Trauma from the phaco tip, the irrigation aspiration probe, or iris retractors. Obviously, here's a patient with more corneal sutures than we usually see after cataract surgery, which suggests prolonged surgery and more instrumentation. And here's a patient with TASS. Retained lens material. The powder from the surgical gloves can end up inside the eye and cause TASS. And certain contaminants on intraocular lenses, which again has been mentioned, so either heavy metal residues or different chemical residues, all of which can contribute to TASS. So these are surgical intraoperative factors. There's a large number of chemical or drug factors, the infusion solutions, any adjunctive intraocular medication. So in the US, this is currently very controversial right now, but more and more centers are using intracameral antibiotics. So any foreign substance introduced in the eye can contribute to TASS. Lidocaine, phenylephrine, triamcinolone, and various dyes, including trypan blue, which I think was mentioned earlier, and indocyanine green. Certain viscoelastics have been linked to TASS. And again, any detergent or chemical residue on the instruments that was insufficiently cleaned off can lead to TASS. I called these processing factors, for want of a better term, inadequate flushing of the phaco and the IA handpieces after surgery. Heat-stable endotoxins can survive ultrasonic cleansing, which has been mentioned earlier. Contaminants from steam sterilization and autoclaving instruments, again, these heat-stable endotoxins that could survive being heated to very high temperatures, heavy metal impurities, and finally, incomplete rinsing of enzymatic detergents. And the post-op factors have been mentioned, and one that's been reported more than once is the ointment from the post-op patching or post-op care may find its way into the anterior chamber, and that is a known contributor to TASS. So the questions of what can I do? Well, clearly, again, we want to follow the manufacturer directions, read the instruction manual for all instruments that are used for equipment cleaning and sterilization. I'd never heard before the suggestion that ophthalmology residents should spend time working with the sterilization equipment, but certainly that makes a lot of sense to me. Avoid inadequate flushing of phaco and IA handpieces, which is another way of saying make sure they're flushed adequately. Always important to avoid any sort of contact between the lens implant and the surgical gloves. Even non-powdered surgical gloves have chemical residues that will end up on the lens implant and end up inside the eye. Be careful with any intracameral medications, especially new intracameral medications that you haven't used for a long time. Be careful with ultrasonic bath cleansing of instruments, and be very, very careful with enzymatic cleaners. If you must use enzymatic cleaners, use copious volumes of water to rinse them extensively, and a final rinse with sterile water. So I don't practice at the main Bascom Palmer in Miami. I practice at a satellite facility in Naples. This is about 130 miles away. It's on the Gulf of Mexico. We have an outpatient only ambulatory surgical center, and this is our protocol. So this may or may not work where you practice, but we've been open 7 years, and to my knowledge, we have not had an episode of TASS. So during the case, instruments are soaked with sterile water on the sterile field to avoid the buildup of materials that might contribute to TASS. Following the case, instruments are sprayed with a neutral, non-enzymatic detergents. This comes from a company called Belamed in Zug, Switzerland. This is called Belamed Protect. The instruments are manually cleaned and then rinsed. Following this, instruments are cleaned in an ultrasonic washer. We again use a Belamed product called 565 Plus. The instruments are manually inspected with a magnifying glass and then processed in a sterilizer. We do not use short cycle or immediate use sterilization. We don't do flashing in Naples. And we have extra surgical trays for high volume surgical days, so we don't run out of trays and we don't have to resort to flashing. And finally, if mitomycin C is used on a glaucoma procedure, those instruments are separated from the tray and processed separately. So again, our take-home points, just to reiterate, TASS is not a never event. The idea that TASS happens doesn't mean that you did something wrong, and it doesn't mean that anybody's at fault. This is typically a non-infectious inflammatory response to some substance that was introduced into the eye either during surgery or shortly after the surgery. Sometimes the cause is never identified. Follow manufacturer directions for proper cleaning and sterilization. And always, always ask yourself, what did I change? Did I do anything differently? And with that, I thank you.
So any questions from, or there were a couple of comments from the panel?
Just quickly go to two questions I received. So one question is, can you look at the manifestations and predict the cause of TASS? For example, fibrin film on IOL, then think of IOL toxicity. Hypopyon, then think of ocular viscoelastic substance. Corneal edema, balance salt solution, etc. I'll ask Dr. Sabyasachi to answer this query. Sabyasachi, are you there? Anyone from the panelists?
Probably Dr. M.S. Ravindra, who's a Dr. Schwartz?
I think that's a great question. I'm not sure that you can necessarily point to any one clinical manifestation and say this is what caused the TASS. And then you did mention a hypopyon, and certainly some patients with TASS will have a hypopyon. But personally, I'd be concerned if I was dealing with an individual patient with a hypopyon that it was not TASS and that it was endophthalmitis. And I think it's been mentioned a few times already. If you're not sure, individual patient, you're probably better off treating that eye as if it were infected.
That being the case, but I know why Pato is asking the question, because as uveitis people, when we see where is the focus of the inflammation, if it's around the lens, then we assume that it's a lens that may be causing the reaction or something related to that, or the lens process.
There is another question from the audience. So the question is in two parts. The first part is when to do an AC tap in patients with suspected TASS, and how often to repeat ultrasound scan if there is some vitreous echo. So I'll ask Dr. Rajiv Brahman is here. So can you tell us?
Hi. I think the practice which we follow at Netrale, when we have a patient where we suspect TASS, I think most important is keep a close watch. We don't immediately poke a needle for an AC tap, but these patients start on steroid. If there are all clinical features of TASS, we preferably even admit them, or if in the outpatient, we ask them to put frequent steroid after shaking exactly what you said. And probably a couple of hours, we start seeing the response. If there is no response, definitely err on the side of infection. Don't hesitate doing a tap and doing a microbiology on them. As far as ultrasound, definitely as a first step, we do it because we want to know whether there is vitreous involvement. If you can see the retina well or vitreous cavity, no need to do. But because of the corneal edema, better to do a ultrasound B scan initially. And subsequently, we do expect that if it is TASS, couple of days, it should resolve. However, if view is not there, if it is worsening, repeat the ultrasound, preferably every day.
So we'll just ask one question to Dr. M.S. Ravindra, because I think that he has been doing a lot of cataract surgery over many, many years now, and a very prolific cataract surgeon from Bangalore. So the question that was still unanswered, if you have different manifestations which we are all clubbing under TASS, so the exact site in the anterior chamber, would you be able to push it to what kind of, what is the source, potential source?
Thanks, Dr. Somshila. Am I audible?
Yes, you are.
Fine. I would like to recall one incident where we started using moxifloxacillin as a prophylactic. Exactly 0.05 ml of commercially available intracameral moxie I was injecting. That amounts to about 500 micrograms. I used to inject initially at the pupil area, and I had no problem at all. There's no difference in the endothelial appearance pre-moxie and post-moxie. But whenever you inject the injection into the pupillar area, then you'll have to reform the chamber. It collapses. So I started injecting close to the tunnel without losing the chamber. And suddenly I had 2-3 cases of endothelial, haze post-operatively. And I did not realize that's the reason. We went and did a lot of exercises as to why we have endothelial decompensation unexplained. Then I could relate it to once I went back to the pupillar area, then it disappeared. So injection of moxifloxacillin, I discussed with a couple of my colleagues, into the stroma at the tunnel. Some people have the habit, or close to the endothelium at the tunnel, at the way the tunnel ends into the anterior end of the tunnel. Moxie is dangerous to the endothelium if injected in a larger quantity. So do not cross 0.1 ml. Once I wrote this on in social media, couple of people called me. I injected 0.3 ml of moxifloxacillin thinking that I have a complication and I will not have it. But those cases have ended up with endothelial decompensation. So moxie is definitely an element which we'll have to keep it in mind, and we'll have to be very, very careful about it. Number 2, Dr. Somshila, if I have time, permit me to say that endotoxins are from killed bacteria.
Right.
When you store an instrument, you see, I do a surgery today and I wash the instrument and wipe it and keep it. It's impossible to dry that instrument completely, like the crevices, the bores, the tubings. If I keep it till tomorrow morning, if I keep an instrument in wet state without autoclaving, the bacteria will multiply exponentially. You cannot even count the number of bacteria, but one bacterium becomes in 12 hours time. It goes into +8, +9 like that to the power of. So my request to everybody who is looking for minimizing endotoxin levels being produced in the operation theater is never store a wet instrument overnight. Mm-hmm. Always, even if you're not going to use it, dry it up by whatever means you have. We would actually autoclave them. We autoclave them. We have a B-class autoclave, so it keeps the instrument bone dry, and it kills the bacterium, and also it prevents the multiplication. This is one step that do not store overnight unsterile instruments. I mean, this applies to the manufacturer. I know that manufacturer, to make a hydrophilic lens, it takes a couple of days time, and they store it. It's an unsterile process, and then ultimately they sterilize it. So when they take it through the process of polishing, lathing and polishing and all, it's kept in moist state. Bacteria will grow and endotoxins will percolate into the especially hydrophilic lens. So that's an unsterile process. And the end of it, they wash it and then autoclave it. But you will never be able to remove the endotoxins that are already built into that. So that's Haripriya gave a fantastic lecture. The measurement of endotoxins level in every batch is important, and we should be available to the surgeon on asking. So many days we have had, the TASS going on, and nobody has quoted or nobody has inquired, nobody has generated a report of endotoxin. It's very easy. A lot of labs can generate this report. And she said the limit is 0.2, and ideally it should be 0. Ideally, it should be 0. And washing the lens with saline on the table will not remove the endotoxins. It may reduce from 0.3 to 0.19, but it will not remove it. So that's an eye wash. So it has to be very low at the place where it's manufactured.
Can we go ahead with the presentation that Dr. Namrata wanted to share with us? And while she's sharing, I think, Dr. Ravindra, the manufacturers have sent a report of the endotoxin levels. I'm not sure. Maybe the others would know, but we'll just go to the presentation. And after that, we have all our cases. Yeah.
I don't think they have sent. Who has received the report?
I think
so
it was
they are not-
circulated on social media.
No. I'll just tell you the steps taken. I'm sorry, the presentation may not be in the format that it is supposed to be, because this is being done. This is being done just now, and we have received responses from our members. 21 responses have been received, and I will be showing you the results of 18 because that was analyzed till yesterday. Till today morning, there were 21, and I'm told there are more today. So the way forward, the first communication I think we sent to everybody, because this was the list which the manufacturer gave us. And this was communicated to everybody to refrain using these batches. But I'm told, and in the several groups, there were other lists also. So they have been circulated today again, adding these, and there may be many more. So this is not a complete list. This is not a complete list. Also, because we wanted to do survey on TASS for this particular episode, Dr. Lalit Verma, our president, helped to design this TASS survey to all our members, and this has gone. And like I said, that we have received more than 21 responses, which means that people have had more than one case. So we have more cases as compared to the responses. Then we also requested our managing committee members from the various states to request for sealed samples of visco, BSS, intraocular lenses, etc. And also asked our AIOS members, as well as ophthalmologists, not only AIOS members, because all ophthalmologists may not be AIOS members, to send samples to the AIOS headquarters so that we could get it evaluated. This was the way forward, which Dr. Lalit Verma, president, again had envisaged this to do the steps forward, or to go ahead as to what we are going to do in future. So this is again today, this communication must have reached all of you, and this is that has advised. This was as per the meeting which was held yesterday, that we have to actually fill up the medical device adverse event reporting form, as well as through the app you can directly report this, or can report to us and we can send a cumulative report as well. And these were the responses. Actually, there were 18. One was mine because I wanted to see how it goes, and so we deleted that. But these are from the various hospitals. And if you see that the number of affected cases maximum have been 4, otherwise 1. Maybe others have not sent their reports, and I would request everybody to send so that we have the correct figure with us. And there have been more than 1 surgeries as well. So patient factors also we wanted to look at. So most were diabetics, although there was hypertension and lipidemia. And these were the varying types of the clinical features. Some said there was corneal edema, AC chamber reaction, etc. And onset of the time of the surgery, if you note that it was within 24 hours for almost all of them. Pain was not present classically in most of the cases, although there were few cases where pain was present. Corneal edema was the most important finding, which was present in most of the cases. They did respond to steroids, and the response was good, for varying from good to fair in most of the cases. Pupil was dilated in 2 and normal in the others, and fibrinous membrane with sluggish reaction in the others. Intraocular pressure was was normal in 6 and was raised or not checked in others. Then no growth was seen, bacterial or fungal, in the cultures of vitreous tap. The posterior segment evaluation for most of the cases, some of the cases could not be done because of the corneal haze, but wherever it could be done, some of the cases, like 4 cases, reported that it was normal as was expected. Then grade of the TASS, if you see, it is from mild to moderate to severe. Severe cases have been reported also. In two eyes, they were severe, and rest of the other mild to moderate. Most of the cases were of phacoemulsification followed by SICS and even ECC. Site of incision was corneal more than scleral. Sutures had not been given in most of the cases. The method of sterilization was autoclave for most of the cases. Tips were being reused, and also the IA tips, as well as cannula. I think this is a practice which is followed in some of the centers. Then what were the products which were introduced into the chamber during the procedures? There was a list of the products by each of the respondent that it is actually ranging from viscoelastics to trypan blue dye, etc. Pilocarpine as well as epinephrine. And then hydrophilic acrylic lens was most commonly implicated. again, not only we've received from several of the companies, also one isolated lens from other companies is also there. The trade name of the lenses have also been made so that we can again warn our members. And the lot numbers are also there. Most people had been using BSS, but some were using ringalactate as well. Of course, we need to analyze this in a more cumulative way because I just had to present it. So I just converted the Google Sheet into the PowerPoint form. And I think when we have more responses and when we have a more robust data, this can be again crystallized. And again, you can see that people have used several of the viscoelastic agents. I think cumulatively, again, we will have to analyze this, as well as intracameral antibiotic, which was not used in 4 eyes, but was used in the others from various companies. And even vancomycin has also been used, and also intracameral anesthetic agents. The various dyes from the various companies have again been used. Like I said, that yesterday we were talking that we do need a control group also to see whether these have been used and compare it with this group. And this we can only do after we get the data. This is for intracameral pilocarpine and the suspect product, if any, according to the respondent. So this is what I had to present, very preliminary data, which needs to be analyzed. And the communications have been set. And I think I would request Dr. Lalit Verma to tell us about the TASS registry, which we are going to launch very soon.
Thanks, Dr. Namrata. We'll have Dr. Rajiv Kumar Das at least start sharing his screen. Dr. Das is presenting the first case. We have 5 cases to go, and we have a hard stop to end the session at 9:30. So we're going to do that. Rajiv is going to present his case. He's from Assam Medical College. Sir?
Yeah. No, the only purpose of creating a TASS registry in one line, I'll say, is to have a continuous kind of monitoring by all the members. So as SCARES has also done it, so AIOS also will do it. We'll have it on soon on our website. Thank you.
It's an excellent endeavor. Thank you very much.
Yeah. Thank you, ma'am. Can I go ahead?
Yes, please.
Thank you.
Please go to full screen. Yeah.
Ma'am, is it available? Is it full screen?
Not on my view. Is it full screen for you, Partha? Anybody?
Not full screen. Can you just click
a full screen icon at your?
But here I'm being my full screen, ma'am.
Okay, fine. It's not a big issue. You can go ahead and present it.
Okay. So thank you all for giving me this opportunity. Actually, I've been encountering 6 or 7 such kind of cases. So recently, I encountered a 60-year-old gentleman, and I have operated his right eye for cortical cataract, manual small incision cataract surgery. He was a non-diabetic, and there is no history of any major illness. And the surgery was perfectly fine. It was an uneventful surgery.
Dr. Rajiv, so I think your slides are not moving. Would you like me to share your slides once?
Sure.
Just could you unshare the screen? I'll help you out.
Hello?
Yeah, just a second. I'll share the screen, sir.
Sure.
Is it okay now?
Yeah, it's okay. Fine. It's okay to others, ma'am?
Right. Yes, sir. You can always let me know. I can skip the slides. Sir.
Okay. So please go to the second slide. Yeah. So in the first post-op day, there is the patient complained of decreased vision, photophobia, and mild pain. Eventually, in the overnight, actually, he was perfectly fine and comfortable. I inquired about it because I have encountered 6 or 7 cases. So, in the next day, next slide, please. That means the first post-op day, I had encountered marked corneal edema, and there is severe anterior reaction, 3+ cells, 3+ hair, hypopion, and all of the all of the nightmare findings. Next slide, please. So this is the finding. You can see there is no lid edema, and only there is a mild hypopyon and a corneal edema. Next slide, please. So definitely, frankly, I want to administer intravitreal vancomycin and amikacin because I think it might be endo, and I don't want to watch the golden time. I also did an ultrasound B scan, and the vitreous tape was perfectly dry, nothing. And started prednisolone, state moxifloxacin as usual, along with the other topical medications. Next slide, please. So you can see the ultrasound picture. My 6 or 7 cases like this. There is a part echo shadow just behind the lens. Nothing in the vitreous cavity. It is just in the vitreous cavity. This is just artifact, and in the right side, this is the picture after giving intravitreal injections. So then I thought that it may be some kind of other things. Then I administered oral prednisolone, Visolon tablet as per the body weight. Then you can notice the organized inflammatory deposit just over the lens. It is a typical finding in my 6 or 7 cases. So when I administered oral prednisolone, then the culture was there is in the after 48 hours, the culture report is negative, perfectly negative. Corneal edema reduced, and media it's clearer than before. Next slide, please. So you can see, and the third photograph, there is corneal edema, corneal haze, and day by day, it's in the patient in the first week. The end of the first week, the patient becomes the media is more clearer, the symptoms resolving. Next slide, please. So by end of the 10th day, the picture is like that, and the visual acuity is around 6 p.m. 24. Next slide, please. So I go with TASS because ultrasound scan supports. It's a 12-hour post-op. There was marked AC reaction, mild pain, no upper lid edema, dry vitreous tape. And after giving oral steroid, the patient responds to the treatment. So discussion, I think panelists will do the discussion. Thank you. This is all up to I say.
Thanks, Rajiv. I'll just move on to the next speaker. May I invite Dr. Harshali? So by the time she shares her screen, I have a question for Dr. Lalit Verma, sir. The question is from Dr. Deepti. So the question is, even if it is endophthalmitis, a good number of cases are culture negative, let alone PCR negative. So how to approach such case scenario? I think he is not there. Dr. Vishali Gupta. Madam, you are there?
I think Rajiv could probably take up this question.
Yeah, I'll take up the question. I think what they have asked is a very right thing, that many times you have culture negative. That's the reason to start with, always presume that it is an infection. No, because other features, as we have told, it's not only just that no bacteria means that it's not an endophthalmitis. So I think because we know that you do PCR, you do further testing, you may test it to be a positive for endoph. So it's the clinical scenario. I think treat it as an endoph unless proven otherwise.
Okay. So when you are there, I'll just go and ask you another question. So the reuse of single-use instrument. So what do the regulatory authorities say, and what precautions the hospital or ophthalmologist should take?
I think the reuse of instrument is a big problem, and to be very true, in India we really don't have any regulations for that. FDA has definitely given guidelines, and they say that in Western countries, it's the third party who do the reprocessing. And they do say that hospitals are the third party who are doing reprocessing. They actually are considered as a manufacturer. So it's their responsibility. UK again, they don't encourage a single-use instrument reuse. WHO has given some good guidelines, and they suggest that if it's a hollow device, preferably you should avoid reusing these instruments. And if at all you are still trying to reuse a single-use instrument, there should be a written policy and procedure how you reprocess the single-use instrument. I think, and that each organization should have their own procedure very clearly written down. I think that's something which is there. And again, a question of it's a debate whether the patient should be informed, whether the consent should contain that you are using a reused instrument is something which is very debatable. But to be very true, we don't have a very clear guideline as far as our country is concerned.
Thank you, sir. So over to you, Harshali.
Thank you. I'm Dr. Harshali from Srinetra Eye Care, Trivandrum. I'd like to thank Dr. Parthu and Dr. Santosh Anawar for giving me this opportunity to present this case of a patient who presented with post-cataract surgery, anterior segment inflammation in the immediate post-operative period. So this is a story of a 52-year-old female. Just the salient point, she was highly uncontrolled diabetic when she first presented. So her sugars were in the range of around 400, 450s when she first presented, and she gave history of being treated for proliferative diabetic retinopathy and macular edema previously. So the eye of concern, that is the left eye, she had a visual acuity of just finger counting half a meter with a dense posterior subcapsular cataract and the macula involving TRD, which you can see in the B scan. So she had a pre-existing posterior segment involvement. So the plan was to do the cataract surgery first, followed by a vitrectomy after the control of the blood sugars. So she did undergo the cataract surgery, which was pretty uneventful on 6th December 2022. And she was discharged with just topical moxifloxacin dexamethasone combination. What we did see on the first post-op day was a bit scary. She didn't have any lid edema or significant circumciliary congestion, but she had mild descemet membrane folds with anterior chamber reaction, which was quite intense, and a small 1 mm hypopia. I'm not too sure that it can be seen very clearly in the photograph. The IOL was in the back. The visual acuity, she didn't complain too much because she always had poor vision because of the diabetic TRD. Fundus view was good enough. I could see that there were not much of vitreous exudates or much of vitreous inflammation, and there was this tractional detachment. She did not complain of any pain. So the first day when we saw a little bit of like corneal edema with a 1 millimeter hypopyon, which was there. So B scan also not much of vitreous inflammation. The pre-existing debris and everything were there as was previously noted, nothing markedly that had increased. So while we were instilling the drops in her with the suspicion of both either TASS as well as early end off, we did a review of the OT records and we noted down all the consumables that were used in her, and we reviewed all the other patients that were operated on the same day and recalled them for the early review. So these were the consumables that were used. We had lignocaine that was used, Clearsol was the irrigation fluid, upper visc was the viscoelastic which was used, Ultima Plus was the IOL. No intracameral antibiotics or phenylephrine were used for this procedure. So she was the 12th case of the total of 18 cataract cases that was posted for the day, and the instruments were autoclaved with Statin 2000 for 10 minutes duration. And all the cases, other cases which we evaluated who underwent cataract surgery on the same day were doing quite well. So while we were evaluating this, we put in frequent topical steroids for her and evaluated her again after a couple of hours. but the hypopion remained the same, the anterior chamber reaction remained the same. So to err on the side of infection, we gave a linezolid antibiotic and started with topicals, and still took her for an AC tap with an intravitreal vancomycin and ceftazidime. So we sent for KOH, gram staining, and cultures, which all came in negative. So we monitored her closely for the next 1 week. Unusually, the hypopion did not go away for like 4 days. It remained status quo, neither increased, neither decreased. So over 1 week, gradually the inflammation came down, and the fundus view was like the pre-existing TRD. Nothing that had changed in the posterior segment over this during this event. So now the further course is we've advised her to proceed with the vitrectomy, but she's as anxious as we are. So the point is discussion, like here she was a diabetic which was previously uncontrolled, and that alone would be a confounding more for both TASS as well as for ENDOF. The IOL batch number which we saw did not match from any of the batch numbers that were given from the AIOS advisories. And the question to the panel would be, how soon can we proceed with the next surgery? That is what is planned, the vitrectomy. Thank you.
Thank you. I'm not sure if that was real, like a triple whammy kind of a case with the patient having so many problems. I'd like to invite Professor Schwartz to take up at least some of the questions here, whether the confounding factors such as diabetes, do they have some kind of role in the mechanism of TASS? I know that's not the question, but it was just a thought that came to me. And the third question is something that you could directly answer.
Well, I suppose that diabetes probably predisposes to endophthalmitis because of generally worse wound healing and inflammatory issues. Although, I realistically, right, in the U.S., certainly so many patients are diabetic that it would be difficult to treat them differently. And again, right, so vitrectomy for diabetic traction detachments, that's a complex question also, right? Because one of the fundamental ideas that we've been discussing, for close to 2 hours is that the more invasive your surgery is, the more chemicals, the more instruments, the more whatever. There are things that can go wrong that it's very hard for us to understand. But I think the larger issue of, is this TASS, is this endophthalmitis, is this some other cause of postoperative inflammation, is very difficult, and I think it's hard to know in all circumstances, but the approach you're taking is certainly very reasonable.
Thank you. I think we have fewer retina surgeons in the mix today. We have
I think
Rajiv, and then we also have,
wanted to add one thing, that as far as timing for diabetic TRD, I think once your inflammation is controlled and your macula is threatened and you have foveal involving TRD, only thing, there is another entity called as fibrinoid. After diabetic vitrectomy, sometimes you get a severe fibrinoid reaction. You get those vitreous strands where there is already the risk factors they have told us that if there is a associated more breakdown of blood retinal barrier, but that is also a known fact which appears like endophthalmitis. Again, not sure whether this case who already had a TASS-like feature is more predisposed to these fibrinous type of a reaction post vitrectomy. We really don't know, but that's something we need to keep in mind.
Okay, thank you, Rajiv, for chipping in again. Thank you, Ashali, for a wonderful case. We move on to the next presenter, Dr. Aishwarya from Narayana Netralaya, Bangalore. And for her case, I'd like if the panelist who can sort of be on alert, because I'm going to ask some questions. Dr. Basak, if you're listening in, I definitely like you to be on alert for this case.
Thank you, ma'am. Are my slides visible now?
Yes,
visible, but again, not full screen, not fully on full screen.
Is this okay?
Yes, that is. Please go ahead. So you have 4 minutes for presenting, Aishwarya.
Thank you, ma'am.
Just to push the pressure on you.
Sure. So I'm really thankful to Dr. Santosh Nawar sir and Dr. Rohit Shetty sir to bring me on board for this esteemed webinar. So today I will present a case which is a 58-year-old gentleman who came with gross diminution of vision in the left eye. He had mature dense brown cataract with phacodonosis. Other eye was already pseudophakic. Left eye socket was a deep set eye. We have done his A scans, the IOL master, the lens star. The B scan on the first day was showing vitreous debris and a few dot and membranous echoes of low reflectivity with good after movements. This was pre-operatively, and pre-operatively the specular was also looking quite well with the CD ratios 22-37 and CV of 37. And in systemic evaluation, most of the things were pretty normal, probably except for the fact that platelet counts were slightly on the higher side, 2.32. All pre-op investigations were normal, and pre-op moxifloxacin, nepafenac, and prednisolone acetate was started as a routine protocol. T plus was put on the day of surgery for the surgery to proceed. And the cataract. So this is these are some few snapshots. There was direct job technique was used, and IOL implantation was done under hydroimplantation using bimanual technique was used. Other consumables which were used were Trypan Blue and OVD, and intracameral moxifloxacin was used after completion of the surgery. Coming was CF 1.5 meters, IOP was 10 millimeter of mercury, conjunctival congestion, chemosis, corneal edema was seen, DM folds with flared 2+, and fibrin was seen. Pigments on endothelium and fresh KPs were also seen. So we did a B scan, but again, the B scan was very similar to what we had seen pre-operatively. Half-yearly pred acetate was started, and then our UVR department decided to wait for 2 hours. During those 2 hours, CBC, RBS, ESR, and urine microscopy, CRP were all done, and they were all normal. During this time, since with pred acetate, the membrane started clearing a little bit. So meds were started, and we decided to defer taking the AC tab over here. And moxifloxacin with prednisolone and pantoprazole with homatropine eye drops was started, along with ibuprofen paracetamol combination tablets was started. HIC team was informed. Coming to day 2. So this is how the day 2 looks. Vision was 648 with pinhole 636. IOP was 13 millimeter of mercury. Fibrin had started clearing off. DM folds were seen. Again, the B scan which was done, it showed a few dot echoes of low to moderate reflectivity. And an overall picture looks like this. You can see that the clearance of the circumciliary congestion has come down. Post-op day 3. This is post-op day 3. Vision is 6/9, IOP 15 millimeter mercury. B scan again remains similar, and only a single fibrin strand was seen near the pupillary area, and patient was very comfortable. The moxifloxacin eye drops were now from hourly were taken up, then prednisolone acetate drops hourly, and then pantoprazole, ibuprofen, and lubricating drops were continued with homatropine. Now this is day 5. Day 5, vision is 6/8, IOP is 12 millimeter of mercury, and you can see the DM folds. The fibrin has almost retracted over here, and these are the DM folds which you can probably appreciate in this picture. And I would like to show the specular here. The specular here is pretty drastically different from what it was earlier. So CD ratio is 1457 and CV is around 40 here. So with this, I would like to probably showcase the root cause analysis of this case. If I were to take an infective case or an endophthalmitis case, all these things we would be doing on a regular basis. For example, microbiological surveillance and OT sterilization protocols, everything and anything needs to be taken into consideration, along with the consumables, BSS solution, gloves, intraocular consumables, and the surgeon and the staff factors that we would be taken into consideration. The patient factors, of course, do play a very important role. Along with this, the drugs, whether they are even putting the drugs or not, and how they are putting the drugs is also very important. Over here, in this particular case, Aquastab, Vitrastab, and gram stain was not done basically because of the fact that we were we saw that the fibrin had cleared from day one itself, on day 2, day 3. And still with this, if we were to find out what could be the missing link, going back, I would like to showcase what all we got to know on that day, other than these protocols, that all the saline OVD, intracranial moxifloxacin, as a routine, all the batches which are used in our hospital, we always do pre-op evaluation, as in like all the batches are first tested in our lab, and then only they are used, get the clearance, including the tropicamide, proparacaine, and betadine eye drops, which are always tested. For this particular case, also Bovidic test, MVS team indicators, batch monitoring system, all showed pass for this particular set of the instruments which were used. Process point also defined that all processes had ended successfully. There was no breach. On that particular day, no other case in the OT was reported with such an incidence. And phaco tips, phaco sleeves, and bimanual cannulas and cannulas used for the patient was specific to the set used. And the case has now been reported to AIOS for proper evaluation. This is our protocol, like I said earlier, that all the things that we use on a regular basis are actually, first of all, cleared by our lab first, with no growth after 48 hours of incubation, then only they are brought to circulation. And along with this, if I would probably think about a path less traveled, we would probably think that, two things that we could do, that if at all tears could help us to find out if the inflammatory markers are increased, or if we could find out that a microbiological analysis would help us in probably doing PCR and metabolomic profiling later on. Maybe we could have some more answers other than the routine tests that we have been doing. And overall, if somebody would ask me what was the probable cause, frankly speaking, this was just one case that I had over here in the hospital, and you can see what till actually we complete at least 1 year. So let's see how it goes, and I will get back to you if at all something conclusive comes up. So here I would like to end my presentation, and thank you a lot. Thanks a lot to Dr. Padma Nareen, Dr. Rohit sir, and Dr. Bhujan sir for letting me present this case in front of this august audience.
Thank you very much, Aishwarya. I'm going to make a poor joke, dad's joke. This is not an August audience, this is a December audience. So I was actually asking Dr. Ravindra to be on standby to discuss your case. Can you put the last slide? Or did you have a last slide for questions? Oh no, you said that you're going to get back to us with the results.
Yes, anything else, ma'am, if somebody wants to ask.
So Dr. Ravindra is going to ask you.
It's a tough case to handle because you've almost done everything. You've diagnosed, you've managed it very well, and everything is all right. If in a big list of cases, only one has got endophthalmitis, probably you're not looking at the consumables, you're not looking at the OD techniques. One thing that we'll have to look at is the patient factors, whether the draping was good, whether there was, debris coming onto the surgical field during surgery from the lids, dry eye status. These are the things that you'll have to analyze. The second is, I wouldn't put tears at all in such patients because it'll dilute the focus on the necessary medications. You're putting drops every half an hour, and where is the question of putting additional tears? Many times I've seen they'll be putting tears and they'll be forgetting important drops. So that's second thing I would like to say. The third thing is, I would certainly encourage patients to use it throughout the night, not only daytime, because night is 6 hours, 8 hours. So the bacteria can multiply if it is, or the inflammation could worsen. So at least give a gap of 1 hour, 2 hours. I'll ensure that the relatives take turns in putting the drops, put an alarm on the mobile, and ensure that round the clock medications are available. You've done a good job. And These are the 7 points I could handle. I think the patient is doing well. The surgical time, I don't know whether you tabulate the surgery time, that itself
Yes,
is a
sir.
component.
Yes, it was around 10 minutes, sir.
Tell me again.
10 minutes, sir.
10 minutes surgery. That's fantastic. Okay, it's a mature cataract with a sort of zonular dehiscence or whatever, phacodonesis. I would have expected a little longer time, but then that's one of the important things. And look at the protocol in the operation theater. We record our videos so nicely, but we don't record what the scrubbing station, what the instrument, what they do, how do they clean the instruments, and periodically we should be able to record the video of that and review it, or at least put them on CCTV, and so that they know that somebody is watching what they're doing is an important thing.
Yes, sir. It is under surveillance in our hospital. So the overall CSSD department is under surveillance for the same, sir. Excellent. But yes, in the OT, of course, the microscopes focus on what we are doing instead of what our OT nurses are doing. Yes.
Somebody should be supervising that and acting on it. And,
thank you, Aishwarya.
Do you check, you've done, it's a very good step that you are looking at the analysis of the items that you use in the operation theater. That's a very good step. Not many of us are doing it. Do you also check the what do you call the endotoxin levels of these contents apart from microbiological or
no,
chemical
sir.
concentration?
The endotoxin levels we have not done, sir, except for the water part. Of course, water endotoxin levels we are doing, but for the consumables, no, sir.
I believe I was discussing with somebody a few days ago, and I believe doing endotoxin levels is not a big task. The ready chemicals are available. You'll have to dilute it to 0.2% and then add it. If it forms a gel, then its endotoxins are present in that to that level. So maybe you can add to that in your series of protocols.
Sure, sir. Thank you, sir.
Thank you, Aishwarya. Thank you, Dr. Ravindra. We'll move on to the next case. Yeah, while Manpreet can share her presentation, was there any comment from any speaker? Dr. Lahane?
No. There is no any comment from me.
Okay. All right, sir. Yes, Dr. Manpreet is from RP Center, and she's going to present her case. Dr. Manpreet, again, pushing you to 4 minutes. We can see your slides, very visible.
Okay, a very good evening to all of you. So we are all talking about the TASS outbreak that has just inundated all of us. What happens after this? A lot of them will come to us with sequelae, chronic glaucoma, and endothelial decompensation. So my case series will focus on that. No financial disclosures. So acute phase, we have all seen how to avoid, how to treat. Intensive corticosteroids form the mainstay of therapy. In the chronic phase, we have secondary glaucoma, endothelial decompensation, and keratoplasty may be required for visual rehabilitation. So we describe outcomes of DSEC in TASS. I think this was one of the questions also going on in the panel, what to do for chronic cases. So I'll describe a prospective case series of 14 eyes in which DSEC was performed for post-phacoemulsification TASS. The mean age of the patients ranged from 65.1 plus minus 6.4 years. There was a history of phacoemulsification within the bag IL and TASS in the immediate post-op period, with the vision ranging at presentation from hand movement to 4/60. Of course, the classic signs were present: diffuse corneal haze, limbus to limbus edema, descemet fold, pigment deposition on endothelium, atrophic iris, and mid-dilated irregular pupil with iris atrophy. The CCT range from 640 to 780 microns. So a decision was taken to undergo with selective endothelial replacement, that is DSEC, and not a full thickness keratoplasty. 5 cases were on one or more anti-glaucoma medication. The posterior segment was normal, assessed either using an indirect or a B scan if indirect was not possible. And all these cases had received intensive topical corticosteroids and oral if required for 6 to 12 weeks after the onset of TASS and had a stable IL in the back. Interval between onset of TASS to DSEC ranged from 8 weeks to 15 months. In 2 cases, the DSEC was performed after 8 and 10 weeks respectively with dismal visual and anatomical outcomes. The first case was a 62-year-old female. There was intense anterior segment inflammation with raised IOP in the post-op period with a primary graft failure. A repeat DSEC was done, which again failed. A trabeculectomy was done, optical PK was done, and eventually there was a glaucomatous optic atrophy with a no PLI and failed graft. In the second case, the graft failed in 4 weeks, trabeculectomy was required to control IOP, and optical PK was performed after 6 months with a gain of 1/60 visual acuity. It again failed after 6 more months. Now we knew that we should not go in too early. So for the next 12 cases, DSEC was performed 6 to 15 months after the onset of TASS. Intraoperatively, what we observed was there was a variable amount of pigment release. Descemet was fibrosed and scarred with difficulty in scoring. There was tribal Descemet membrane, which was removed piecemeal in 5 cases. So the end total Descemet that comes beautifully in clean cases of DSEC is not observed in post-TASS cases. Post-operatively, the inflammatory response is much more intense. There is pigment dispersion, and a classic ring of pigment at the host graft junction was seen on slit lamp examination. Secondary glaucoma developed in more than 50% of cases that required 1 or more anti-glaucoma medications. The IOP ranged from 10 to 21 mm, and 6 patients, as I said, required topical anti-glaucoma. Central corneal thickness, dural lenticule thickness was within normal. The corrected distance visual acuity in these latter 12 cases ranged from 618 to 69, and there was no case of graft rejection till the last follow-up. These are some of the post-operative cases of DSEC in TASS. And as you can see here, there is a classical, the red arrow points to a pigment deposition at the graft donor lenticule and the host junction due to the excessive pigment release in cases of TASS. So just to summarize, successful visual and anatomical outcomes may be achieved with DSEC in cases of chronic TASS. Time interval between TASS and DSEC is an important determinant of long-term success. There should be an adequate waiting period, at least 3 to 6 months. A lot of these cases are referred, and there is so much pressure on the operating surgeon from the referring surgeon to operate early so that the visual rehabilitation is early. Do resist the temptation. In the acute stage, there is a lot of incidence of graft failure, secondary glaucoma, and intense inflammation. Inflammatory response in post-TASS cases is more intense, and characteristic pigment ring is seen at the graft host junction, and there is a more than 50% incidence of secondary glaucoma. Thank you for a patient hearing.
Thank you so much, Manpreet. We'll quickly we'll take a couple of comments from Dr. Ritu Arora. My question, Dr. Arora, to you is, I'm sure you must have also faced similar cases of post-TASS corneal decompensation. So what has your experience been? Do you expect more inflammation, and are you worried about higher chances of rejection in your cases?
Yeah, she has done a beautiful series, and my answer to this is that one point which she very nicely said, that don't hurry up for DSEC in these cases. So I also take some time, at least never before 3 months or 4 months before taking up these cases for DSEC. And second, yes, scoring is difficult. Sometimes the whole Descemet membrane does not come out very easily. And though I have not had so much of inflammation post DSEC in these cases, they've talked about some inflammation, but a lot of cases which I've done have been pretty quiet. Though I expected that there will be more reaction, but cases have gone smoothly. Handling pupil has been a problem in these cases, because some of the pupils are like mid-dilated and they just don't move. And but overall, the results have been pretty good. At times, glaucoma does give a problem, but it's manageable.
Thank you. We will go on to the last presenter. So he's not a presenter, surprise, surprise. But Sabyasachi has published the largest series, perhaps, at least in an Indian scenario, about TASS, and that kind of makes him pretty much an expert. So Sabyasachi, what is your, so we've heard a lot of useful discussion in this entire 2.5 hours. So what are your top points that you have that you could share with all clinicians, that if you have ABC, it's most likely to be TASS? That is what we're looking at.
Thank you, Dr. Somshila. And so I was actually not told that I need to present a case, and I don't have a case anyway. So I'll probably try and summarize a little bit about what we have heard so far, and some great talks, on the panel. I think, first of all, traditionally or classically, the thing is that TASS manifests within 24 hours of cataract surgery. And, though Haripriya madam has shown us that it can have slightly delayed presentation, especially if it's because of the IOL. But then, the later the presentation and, onset after 24 hours of surgery would tilt it more in favor of infection. and not sterile inflammation. So I think that is a very important point that especially anterior segment surgeons should try and note. Second thing is, it's always good to dilate the pupil, even if it's post-op day 1, and try to look inside. And with a good indirect ophthalmoscopy, very likely you are able to see the disc. It's like a sort of a headlight in the fog kind of thing. But then, if somebody is used to doing indirect ophthalmoscopy like we retina surgeons are, you will likely see the disc. And if you see the disc, it's very likely that the vitreous is relatively clear. So, and these diagnoses are all diagnoses of let's say they are clinical diagnosis. Whatever the culture reports look like, and also try and do an ultrasound on that post-operative day 1. So if the pupil dilates well, you're able to see the posterior segment, at least the disc, and the ultrasound is relatively clear, then it's again more in favor of TASS. So in the initial first 24 hours onset, with a well dilating pupil, not much of pain, the eye looks relatively white, and vision is not as bad as the clinical picture looks like. Patient still sees 624, 636, despite a lot of corneal edema as well. And the ultrasound is relatively clear. So these are the general points which point towards TASS on postoperative day 1. And the later the onset, the more the likelihood of endophthalmitis. Secondly, I think, also if you look at my series of, or rather our series of 60 cases, there were 2 outbreaks, and they constitute about 40 to 43 out of the 60. So I think TASS generally happens, because it's really not surgeon related and not much patient related either. It's all to do with the consumables which are going in. So generally, even if in a private practice, you may see 1 case, but then a lot of other peers are also going to have, like we are seeing over the last 2 months, this is happening, right? And we are coming to life now, but then this is actually happening over a long period of time. So TASS generally happens in outbreaks, responds relatively well to topical antibiotic steroids, because we can't stop the antibiotics. So topical antibiotic steroids do a very good role. And, also in our series, if you see, out of the 59, I think out of the 60, there were about 25 who had more than 1 year follow-up. And, none of them really had any visible corneal decompensation or secondary glaucoma or so, though Manpreet has shown us a nice series, but then these are relatively rare and, it's very rare actually. And all of them will get funneled into either AIMS or LV Prasad or, some of these large institutions, but private practitioners probably would not see some of these cases. So, I think in a nutshell, this is what over the years, and also I have reviewed a lot of papers on TASS over the last decade or so. At least 15 or 20 papers I have reviewed also. So over the years, I think that's where my learnings have been, that there can be exceptions, but this is generally where TASS falls in literature.
So that's great learning, Sabyasachi. So one is that it's not the surgeon's fault or even the manufacturer's fault. TASS is extremely rare, but it can happen. Second is that we need to differentiate between endophthalmitis, which is also rare, and only in this very severe TASS or in early endophthalmitis, we may get confused and we may go wrong. So like all the speakers have highlighted, it's important to err on the side of endophthalmitis. The third important point is all is not lost. They do respond very well to topical steroids. And the fourth point is that some cases be very severe, but still we may not lose the eye. We can send the patients to us, to the corneal surgeons, and then it's up to us to take care of these patients. So with that, Partho and I will end our part. Partho, over to you, then we headed back to Dr. Santosh.
Yeah, I think it was a nice experience participating in this webinar organized by IJO. So I hope all of us had a lot of learning from this discussion and the case presentation and the talk. Over to you, sir.
I just want any final comments by any of the panelists. Not all of them are there, but whoever is there, Dr. Professor Arora, Dr. Lahane sir, Ravindra sir, if Vaishali, Namrata,
I think Santosh, it was a very fruitful discussion, and every part of the TASS and differences of the TASS treatment, every part was covered very well. So really, I appreciate this, and this will be very useful for the treatment also, for the diagnosis also, and this will give them good guidelines for all these surgeons also, so that to take care of the all operation theaters and everything in the operation theater. Really, I appreciate the discussion. Thank you.
Thank you.
Yeah, I just want to say that just share in 2 minutes our experience, which we had. We've had these kind of, TASS experiences maybe 3 to 4 times in the last 4 years. And every time it was by exclusion, we could come to that this is the cause. Because we are in a setup where, everything is available from the government. So it becomes different, what kind of consumables you are getting. So the recent last 2 months, when we had like a lot of cases coming with severe reaction, like unexplained reaction on the first or the second day, and multiple times when we had meetings, and we realized that the IOLs were being used from a particular company, hydrophilic IOLs, which were available in the hospital, which hospital had procured. And though we couldn't blame the IOL right away, it's only when we realize that because in pediatric patients, we don't put hydrophilic IOLs, we are going for a better brand IOLs and hydrophobic IOLs. And, and all the samples which were used in the hospital, they were sent for microbiological investigations number of times. We never found anything microbiologically, anything in any of the samples. And we realized that cases when the hydrophobic IOLs were used, or say maybe a Acrosoft kind of an IOL or a J&J IOL was used, there was no reaction, there was no TASS. But the other cases where the other hydrophilic IOL was being used, we started noticing those kind of reactions. And then it is not only that the IOL which we need to blame, it is also at times the injector which is supplied with those hydrophilic IOLs. Those injectors and the injector tips which are there, then the company specifically told us that we need not to use that injector. They gave us a separate brand of injector, and then we were able to sort out this particular problem. So, we really need to deep dive whenever we are having number of these issues as to what is the problem. And at times I have seen when we say moxifloxacin, again, nothing against other companies, but when moxifloxacin of one particular well-known company is used, we don't get any reactions. But if moxifloxacin from other companies is used, I don't know if others have had this kind of an experience, we do get at times little more reaction. So I'm very, very particular about, what is going inside and what company, because we need to maintain that particular standard. Nothing against any company, but that's what happens, because sometimes the same trypan blue which you use from a particular company stains the capsule very well, and other times it is very light. So there's definitely the standardization in all the products is not there. And that's the reason we are getting this kind of a problem. That's what I feel at the moment.
Thank you very much, Dr. Ritu. Dr. Santosh, just before the others, I just wanted to thank you for putting this together. Dr. Santosh is the type who works from the back, and he seems to be giving Parthu and me credit. I'm getting some messages saying what a nice webinar. I just want to put it up front that this is IJO and Dr. S.H. Santosh on our show. And it's scientific. So I like that he's putting all the evidence together with wonderful speakers, including Dr. Schwartz and Sabyasachi and all the other speakers, Dr. Haripriya, Arvind, and Partho, of course. So to bring together such a wonderful seminar. So we still have some more conclusion.
One request is, for the moderators and also Sabyasachi Sen Gupta to put your heads together and come out with clear guidelines. Evidence-based guidelines which we can very quickly publish. Of course, Dr. Schwartz help, and whoever are the experts, so that's useful for the members. This is not going to end soon. These cases keep happening once in a while. So it's a good idea to kind of put together a review article or evidence-based guidelines.
Thank you.
Well, I would just like to put in a note that thank you everyone. Till now, we have had 1,000 views, and just few minutes back, the number was 777. So it's all for the good luck. And this is like one of the highest views that have been reported. So great. And thanks a lot for all your contributions.
Thanks for tracking.
Thank you. Thank you very much.
Hard work, Rolika. Rolika is the Women Friday behind the scenes. Also, Sunil, thanks for all the help
It's all Sunil ji. I'm just helping Sunil ji here. Thank you so much.
Thank you so much.
So much.
Thank you all.
Thank you. Good night to everyone.